the CaVenT trial, which looked at standard anticoagulation versus thrombolysis. An older study was completed in 2012, still very relevant to these patients all the time, and it raises a lot of good questions, so that's why we're talking about it. So, on just in general for the study, that DVT occurs in approximately 1 in 1 persons per year, and the proximal DVTs comprise the majority of symptomatic DVT. So more distal DVTs aren't usually, don't tend to be symptomatic. So a little bit more background. Even treated with anticoagulation, 50% of patients go on to develop some degree of post-thrombotic syndrome. So what is post-thrombotic syndrome? It's a pretty debilitating disorder, and we've all seen patients who look like this. So basically it's characterized by pain, a sensation of heaviness in the affected lower extremity, hypertension, skin break, and development of venous ulcers. Pruritus is a pretty debilitating condition, has a lot of effect on the patient quality of life, and there have been many studies actually looking at cost of the medical system, and having thrombotic syndrome is significantly more of an expense to the medical system than having DVT alone. Showing the characteristics of post-thrombotic syndrome that we're all pretty familiar with. So what happened? Basically, the blood clots, there's both a mechanical and an inflammatory component. Basically, the thrombus damages the venous valve, so there's reflux, and inflammation also damages the valve, so there's chronic reflux, chronic basis of blood in the lower extremities, leading to symptoms. Of all patients with DVT, lower extremity DVT, go on to develop post-thrombotic syndrome. How can people prevent this? Basically, the compression stockings does decrease post-thrombotic syndrome by around 50%, and this is all data that's cited in the CaVenT trial that I'm just bringing up here. But basically, the compression stockings decreases the risk by around 50%. So that still leaves around 1 in 4 patients who have DVT with chronic post-thrombotic syndrome. A large proportion, 25% of patients who have DVT will go on to develop chronic post-thrombotic syndrome despite the use of compression. What work led up to this study, the CaVenT study? Basically, they took a study by Watson, which was a review of 12 studies, around 600 patients, and they looked at systemic, not catheter-directed, but systemic thrombolysis, and compared it to conventional, medical therapy with heparin and warfarin, and they found that there was a significant in post-thrombotic syndrome in patients who were treated with systemic thrombolysis, but there was a significant increase in bleeding rate or in complications with in the treatment group. This them to think, what if we deliver therapy locally with systemic side effects and still possibly gain the benefit of reduced post-thrombotic syndrome complications. There was a lot of case review series that had been reported as well, which basically showed that catheter-directed thrombolysis showed a decrease in post-thrombotic syndrome, but there was a control group in those studies. So basically they thought that this would be a good way to I don't know, I got kicked out of here. Devices they were going to in is the Unifuse system, which is basically a catheter. Actually, if you guys aren't familiar with catheter-directed thrombolysis, it's usually, if it's in the lower extremities, usually make a puncture in the popliteal artery. You thread the catheter in. Catheter has multiple side holes where TPA is infused, and then attached to the in the popliteal vein. There's also heparin running, so you have TPA and heparin running. So this is a typical system, the unifuse system. They wanted to examine whether this catheter-directed thrombolysis with alteplase, specifically with alteplase, for acute iliofemoral DVT, improved long-term outcomes. Looking at iliofemoral DVT because it tends to be more associated with the development of post-thrombotic syndrome compared to more distal DVT. They were looking at the primary endpoints they looked at were iliofemoral patency at 6 months, as well as post-thrombotic frequency at 24 months. And thus the diagnosis of post-thrombotic syndrome was made by the Villalta scale, which is a combination, I'll get to it in a little bit, but it's a combination of subjective reported symptoms and objective physician-reported things. Secondary endpoints included clinically relevant bleeding, recurrent DVT during follow-up, and post-thrombotic syndrome at 6 months. The reason 24 months for the primary endpoint was because there's been say that post-thrombotic syndrome should only be diagnosed at 24 months follow-ups, and at 6 months you shouldn't really be diagnosing it that early. Study design, basically the study was multi-center and it was open label. Anyone have any thoughts about the fact that the open label trial? What do you think about that? Just make this more interactive. Oh. Anyone else about that?
The open label.
Open label means that both the patient and patient was aware of the therapy that they received. So obviously it's tough to blind someone to the fact that they're getting a procedure. Has been done. For example, the Simplicity 3 trial, I think it was with renal denervation. They did a sham procedure compared to renal denervation, and that was a pretty good trial. And it showed that there was no difference between denervation therapy in hypertension, reduction in blood pressure compared to procedure. So this was not, compared to procedure, but the studies actually thought that it would be unethical to do such a thing, and it would be almost impossible to blind someone to that. But they mentioned, there's an increase to bleed in a patient who's on anticoagulation already. You're going to do a procedure puncturing the popliteal vein and not necessarily do anything. It's kind of could be unethical, but it does bring definitely some properly reporting bias.
Yeah, time you have that sham limb is so critical for the placebo effect, and it's hard with interventional procedures to do a sham limb, but it really showcases what portion of your effect is truly placebo versus not.
Eligibility, the patient time acute iliofemoral DVT, it has to be above the thigh level, as we discussed. It was iliofemoral. Symptoms, actually, they extended up to 21 days, which gets to the acute, to the subacute stage, not quite, but it's kind of a long duration of symptoms. So who had up to 21 days of symptoms was able to be included in this study. I think it was around 6 days of symptoms. And basically, the patients could not have any increased risk of bleeding. Pretty much the table 1 of the inclusion and exclusion criteria from the study. Any thoughts about these? I think the one thing since we have with DVT, disease, and that's one of the exclusion criteria, but it's understandable that if you're going to give thrombolysis, you want to watch out for, malignancy, that maybe they can bleed from their malignancy, which has, kind of vasculature inside it. I think they're pretty reasonable criteria.
Yeah, especially the intracranial hemorrhage risk if they have intracranial mets, so that's always a concern when we're doing thrombolysis in patients with stage 4 disease.
inclusion criteria might be a little too wide, given the fact that the venous incompetence is a lot higher in those people under that near 75 and compared to the 18-year-old.
That's I mean, I believe that they they didn't exclude like venous stasis symptoms beforehand. You're right. That's a great point.
The cutoff for thrombocytopenia at 80. You guys, that's we got.
Yeah, I mean, why cytopenia of any sort? I mean, is it heparin-induced related? Is it, why do they have that? Is it liver disease related, which can add the risk of bleeding, et cetera?
Yeah.
Points.
Moving on to the next section, randomization. Basically, they had 209 eligible patients. They randomized 108 to treatment only was low molecular weight heparin, which dalteparin or enoxaparin with warfarin. Heparin bridged to warfarin therapy to a therapeutic INR of 2 to 3. But that was the conventional arm. And then the catheter-directed therapy plus conventional treatment arm, which had 101 patients. And they also did a randomization for pelvic vein involvement using a block system. Exactly familiar with that that type of randomization, but it's that they were trying to account for groups of patients with pelvic vein involvement and trying to randomize them to each group equally, since that's associated with a higher rate of post-thrombotic syndrome. Also had standardized treatment with class 2 compression stockings, at least daily for at least 24 months. That was the recommendation. They were advised, all patients were advised to use compression stockings. To decrease the risk of post-thrombotic syndrome by 50% itself. The catheter-directed therapy group, they underwent a fairly standardized procedure. I kind of described that before, but I won't get into this in detail. But they prefer that the clinicians got popliteal access. Here's popliteal access picture of the TPA infusion catheter in blue, the heparin running through the popliteal sheath. Basically, they gave them alteplase and they did a venogram to assess clot burden. All this is pretty standard for catheter-directed thrombolysis. What was interesting, I thought, is that they the operators to use adjunctive angioplasty and venous stenting if they deemed it necessary. And I was just, I don't know if you guys have any comments about that. It was interesting that take away a little bit from the adding another type of treatment that's not necessarily included in the randomization.
Phenomena. So if you don't get flow or inflow, then it may not ultimately succeed.
I've had to do that because I think isn't standard of care treatment for iliofemoral clot, which is symptomatic therapy with plastic.
It is certainly becoming for those with like kind of iliofemoral occlusion, usually some mechanical protection at the iliac component, like May Thurner, is stenting with some reasonable radial force stent.
We'll follow up basically and going over a little bit on the Villalta scale. We're seeing at 6 months and 24 months by a surgeon and vascular physiologist who had no knowledge of the patient's medical history or treatment allocation. And the patients were explicitly told not to reveal their treatment allocation. It was interesting. I mean, that's their way of trying to get over the assessor trying to find the assessors, I guess. The Villalta scale, and basically on the left-hand side you see the subjective symptoms reported by the patient, and on the right you see the clinician-rated signs assessed by the physician. And so basically, each of these are scored from a 0 to 3, with 3 being severe. And so basically, if you have greater than 5, with post-thrombotic syndrome. So this is basically the treatment group, and they look pretty similar. I didn't see anything very different in both groups. They were pretty similar. Patient, what actually happened. Of the patients who were allocated to catheter-directed therapy, through from the study and eligibility criteria, even though they were initially enrolled, they further screening they were found to not meet exclusion criteria. And the authors made a good point in the discussion of this paper, basically saying that this brings up the point that they have been not as, maybe the enrollment weren't really enforced very well. So they were enrolling patients who may not actually met these criteria, and only the 4 that were caught that they had brought up in the discussion. I thought that was interesting. Basically, 9 patients had procedure done. There were 2 technical failures, and 1 who had distal femoral DVT that that was not seen on the diagnostic ultrasound or CT beforehand, so didn't receive alteplase and be in the study. Basically, follow-up in the analysis, 90 were included in the catheter-directed therapy, and the standard 99 were included. The directed therapy was 2.4, and just explaining some of the outcomes. 43 patients had complete thrombolysis, 37% had partial thrombolysis, and 10% had unsuccessful thrombolysis. This was of all the catheter therapy patients. There's one actually that we should probably talk about, is the open vein hypothesis, which goes to say that if you refer complete patency of the vein, you have a low rate of post-thrombotic syndrome. Basically 43 patients had complete thrombolysis and 37% did not. So that's just showing you that kind of affects that open vein hypothesis. I jumped to angioplasty and stenting. 23 patients had angioplasty and 15 venous stents were placed. Had actual, I think it was angiojet. No, maybe not angiojet, but they had thrombus aspiration. And basically, percentage of patients who had adjunctive treatment. So if you really want to look at this as being catheter-directed therapy itself, meaning the catheter-directed infusion of TPA by itself, I think that kind of affects the outcome. Patients at 6 and 24 months, both in the coagulation group and the catheter-directed therapy group were being therapeutic in their INR and had similar rates of being compliant with their compression stocking. So these were some variables that were taken care of, and they were much identical in both groups. So they included that. Statistical analysis, so they calculated before doing the study that they needed an N of at least 200 to receive a power level of 80% and a significance level of 5%, and they didn't enroll, they enrolled greater than 200 patients, but actually through dropout and deaths and the intention treated analysis, there was less than 200 patients who were analyzed. So basically, they looked at the chi-square test and 2 t-tests and 2-sided Mann-Whitney tests for analyzing the data. Here's the main outcome, basically. This is the primary outcome. So post-thrombotic syndrome at 24 months in catheter-directed therapy had a statistically significant decrease in post-thrombotic syndrome at 20 compared to standard treatment alone. Iliofemoral patency was also at 6 months was also better in the catheter-directed thrombolysis group compared to standard treatment. You can see the p-value here, but post-thrombotic syndrome at 6 months was not different. Along with the thought that post-thrombotic syndrome should be diagnosed at 24 months because possibly their patient still having symptoms, they go away, and the representative post-thrombotic symptoms. Risk reduction of 4% at 20 therapy group compared to the standard therapy group with a number needed to treat of 7. So pretty good, actually. I don't know if anyone else has any thoughts about those results.
Had post-thrombotic syndrome, and they're completely miserable. So, 1 out of 7 chance of not getting this lead is pretty good.
Which one? What level of Volta were they? Were they like the venous ulcer end?
Venous ulcers.
In either group, right?
Group. I forget the severity scores. But they have any venous ulcers, but I forget the actual severity scores.
So that's the anticoagulation alone or lysis combo got ulcers, most severe form of process, and I think that's fascinating.
The breakdown of patency compared to thrombotic syndrome. This goes with the open vein hypothesis. Basically, patients had iliofemoral patency at 6 months. They had risk reduction. This is in both groups, actually. So if there was iliofemoral patency at 6 months, there was with an absolute risk reduction of post-thrombotic syndrome of 24.4% at 24 months. Compared to insufficient recanalization at 6 months. So that's pretty powerful. I think it warrants evaluation of the open vein hypothesis. The p-value there. As far as adverse outcomes, here's the adverse outcomes. There were 20 bleeding complications. They separated them out into major and clinically relevant bleeding complications as well, except some of the other bleeds. And so the major bleeding complications they had were 1 abdominal wall, hemo requiring transfusion, 1 calf compartment syndrome needing surgery, and 1 inguinal puncture hematoma. The author's conclusions from the paper. This is the first randomized controlled trial to show clinically significant risk reduction in post-thrombotic syndrome catheter-directed therapy. Definitely was a groundbreaking trial. It never done before. It showed an absolute risk reduction of thrombotic syndrome of 14.4% with a number needed to treat of 7. There was no significant difference in development of post-thrombotic syndrome at 6 months, which again goes along with the that it is shown later. Therapy may be so they came up with the thought. This, if we do femoral DVT or more proximal DVTs are associated with a high rate of post-thrombotic syndrome development, then, to say that the therapy may be also useful for treating distal femoral and popliteal lesions, which kind of makes sense. Was supported by this study, because syndrome was seen less frequently in patients who had iliofemoral patency. That iliofemoral patency can be a surrogate marker for of decreased post-thrombotic syndrome. Some study in the future may just look at iliofemoral patency, or when you're actually doing one of these thrombolytic cases, that may to gain complete lumen recanalization, good outcome. And complication rates were acceptable. Basically, the bleeding complication rate was 9%, which was similar to other studies. When they accounted for, this 9% of clinically significant, and there was no patient who was permanently impaired from therapy. Yeah, we talked about this a little bit, and if you guys want to if you guys want to think of off the top of your head that we have. It's not a reported bias, so bias of an open label design. If a patient received the thrombolysis, maybe they're having a indication that it's going to show symptoms more, and so part of the Villalta score is subjective. So maybe they're reporting less symptoms. Could they have gotten a sham study? Again, mass study is unethical. They've done it in some instances. It's tough even. That's a point that I think is sham studies in general. Like, is it ethical to do that? I mean, I don't know. I mean, renal denervation trial. I guess in the renal denervation trial, Simplicity 3, doing an arterial puncture, which in itself has an inherent risk of bleeding. It was a trial, but very successful, landmark, groundbreaking trial. Do you necessarily in intervention trial? I think it warrants discussion. Anyone have ethical or not? Okay, well, selection bias.
Brandon, I was trying to find the unmute button.
Oh, okay, Candace.
I think it's necessary. I don't think it's unethical as long as you're making the patient aware that it's a possible option. But it's really necessary and it provides valuable clinical data. And a lot of studies, if they show the non-procedure, then they'll stop the study and enroll everyone and treat everyone. But it's not ethical as long as they're aware of the possible sham. Even procedure, they've done that in most areas of medicine.
It brings up the point of the placebo effect in medicine in general. Like, it must be such. I mean, I tend to think that it must be such a huge effect of every treatment we do, even whether it's medical or whether it's procedural.
Yeah, the vertebroplasty column-use data was pretty interesting in showcasing no difference. So yeah, I agree. I think the placebo sham limb is important to identify what's really going on.
Bias. There were those patients who were enrolled that I talked about a little bit earlier who really were not eligible. They found that out, during the thrombolysis. They were not eligible to be included in the study. Could have been suboptimal study enrollment, or it wasn't as stringent as it should have been. All 4 patients with true consent. So this, basically, also brought up, is there reluctance towards invasive treatment, or was there insufficient patient information provided? You mentioned the use of stents and angioplasty. If this hypothesis is indeed a correct hypothesis, which it seems like it is on the data, then the stents and angioplasty may have modified the outcome in the catheter-directed therapy group. center aspect of this, was it generalizable? It was only 4 interventional centers in Norway, so that kind of like generalizability, I would say. And also, you know, one of these centers may have had more experience in catheter-directed therapy and therefore better outcomes. So bring the fact that maybe this should be repeated on a more scale in a higher number of institutions. As far as the power, basically, you know, this study was powered to include 200 patients, but only 189 were included in the final analysis. So this brought up the fact precise study. I don't know about what I just said, but feel free to jump in. But basically, this brings us to the tract study. It has not been completed yet. I'm just going to go through it a little bit. But basically, that study kind of addressed some of the issues that were raised by this study, but also pharmacomechanical thrombosis, meaning use of mechanical and pharmacological thrombolysis. Not only seems better thrombus removal, but it's supposedly a faster treatment modality. And I'll get into this a little bit. So again, this is still in open enrollment, not completed yet. So this is the open vein hypothesis that the persistence of thrombus in the venous system is linked to the development of post-thrombotic syndrome. So any to remove the most amount of thrombus and get the best lane, tend to be associated with deep thrombotic syndrome. That's the kind of the hypothesis. So, from catheter-directed thrombolysis, which a lot of us currently use, is currently second-line therapy and DVT that progresses despite anticoagulation. But is there a role? The question this study addressed was: is there a role of percutaneous first-line DVT? Is it a first-line therapy? So basically, they wanted to do something similar to the CaVenT trial. They were going to look at the development of post-thrombotic syndrome at 24 months in patients randomized to pharmacomechanical thrombectomy, standard anticoagulation alone. And the outcomes were kind of similar to the calculation of quality of life symptoms, venous quality of life symptoms. But, in addition to doing the Volta scale for the post-thrombotic syndrome, they were looking at quality of life symptoms. To look at if there were pre-treatment predictors of therapeutic response. The cost to the system is interesting because that's extremely important, especially in this day and age of reimbursement tightening down. And then they want to see if there was anatomic and physiologic that could be assessed to determine, when do you stop treatment in thrombolytic arm. Basically, how much patency do you want to get before you stop, and how is that associated with development of post-thrombotic syndrome? So the center in support trials is in the CaVenT study. It's 40 to 60 U.S. clinical centers. It is still open label. They're not doing a sham trial. Investigator initiated, but there's funding from multiple medical device companies. Again, it's investigator initiated, not device company initiated. And the goal is to achieve 692 subjects, which, a much larger amount than the trial. January 2013, 392 patients have been enrolled. I'm not sure now how many patients have been enrolled. So criteria: patients aged 16 to 75 who have, primal, but they have distal involvement. In the trial, I believe that had distal involvement. That's why they had that patient who was brought in, had the distal femoral DVT. You couldn't get thrombolysis in the end. But here, you have to have proximal, but you can also have distal involvement. You have syndrome as you come in. You can't have it already, and you cannot be a high bleeding risk. So it's kind of similar exclusion criteria to the CaVenT sense. Basically, they did the same randomized block. So the other study did a randomized block randomization of 6 patients in each block. Again, I'm not exactly familiar with this, but they said that probably introduced some bias into the CaVenT trial. This one, they use a variable number of patients in each randomized block. So I guess that addresses some of the bias that was in the other study. When do they stop? Basically, when they initiate this catheter-directed thrombolysis, they stop therapy when greater than 90% of thrombus is removed with restoration of flow. 35 milligrams of TPA in this study, not alteplase, by the way. When 35 milligrams of TPA is given or maximum dose is reached, or there's clinically over bleeding. And so they actually incorporated, instead of just like letting the operators choose when they could step or put PTA, they could put in a little more, stringent guidelines for when angioplasty and stenting can be done. If there's, as we were discussing, if there's an obstructive iliac or common femoral thrombus, they can do angioplasty or stenting. If there's obstructive femoral thrombus, they can only do angioplasty. So all patients get TPA. There's a variety of pharmacomechanical devices on the market. So the ones they included, they had a kind of to which device patients should be used. If there's good inflow on venogram to the popliteal vein, they recommended either using the trellis system, which basically has a proximal inflatable balloon, and basically you pass the catheter through the thrombus, inflate a more proximal balloon, and then a more distal balloon, and in TPA. And in the interim between the two balloons, there's kind of a curved kind of sinusoidal configuration that rotates, and that's how it disrupts the thrombus. And then after you are done with that, after you're done with the set infusion time of the TPA and the rotating thrombolysis, or mechanical thrombolysis, you aspirate the thrombus. So that's one system. And the other one is the power pulse thrombolysis with the angiojet system. Use sort of a rheolytic system, infusion and sucking at the same time to pick up thrombus, all along with the infusion of TPA. A poor inflow to the popliteal system, they recommended first doing catheter-directed thrombolysis, as in the CaVenT study, to induce TPA, and then afterwards it's up to the physician which device they use. But it is that the CaVenT trials. I don't know if anyone has any thoughts about the ATTRACT trial, how it's set up. I think it's really exciting. It's going to be pretty cool to see the results of that, and it's going to be the way we treat DVT. Change it, it'll give us some good data.
Hey, just a question on that second last slide that you showed, where you trellis system. Do you mind just going back to that slide, please? Second bullet point from there.
Yeah, several devices out there in the market now. Angiojet work in Bernoulli's. You get power pulse spray where you inject kind of lytic and CLOT, and it just embed it there for 20-30 minutes, let it sit there, do its trick, net it out, hopefully thinning the thrombus a little bit. Is the two balloons, and then in between the two balloons, you're supposed to have no flow. You lytic, let it sit there, bathe it, and using that kind of sine wave, it sends it and then translates superior and inferiorly, kind of set up the CLOT. Then the ECOS, which is a catheter, to kind of bake up the fibrin bronze and allow the TPA to work more effectively. So there's all these different techniques. I've used just a catheter before and just aspirated CLOT, so like a big guiding catheter, like an 8-French guide catheter, and you can surprisingly suck out a lot of CLOT.
other things that are really robust for large bore clot, like IVC clot that's acute, like the angiovac, which is basically put the pump and then a fusionist pump, and you'd have veno-veno bypass and suck out big chunks of clot. So there are methods of mechanical or pharmacomechanical thrombectomy that you can use. Well, now the question is, Brent, does this change your approach to seeing a patient with the DVT? How do you approach it? It was like 20%.
Yeah, clinically significant. I think it was 9% in the trial. But
so,
yeah, I think it is a low. It's a low bleeding that actually has a clinically significant problem. And, the ultraplace doses they were using are usually what we use nowadays. We use TPA. I'm not sure the equivalent dosage to ultraplace, but for acute DVT, I'm conservative still, to be honest. I probably would still, even though there is that, it had a lot of good results. There's a chance that I may be hurting someone with bleeding. It depends a lot on patient selection. Like if someone's really young, have a lot of life. If they have a pretty active lifestyle, I'm going to be concerned that they're going to get this post-thrombotic syndrome, and I'd probably be more aggressive.
The question is, how significant is that post-thrombotic syndrome truly going to be? Like, is it really their cue of valve or not? And have that much impact?
Right. To look at how they stratified, I remember if they actually stratified patients in the CaVenT trial to severity of post-thrombotic syndrome, but that would be pretty important, I guess. How about the way you treat patients?
Functional status, and not and then I'm still going to treat them. And
yeah.
I've asked to do a cut down and use Fogarty and do an embolectomy and pull them up and do heparin therapy. I can do a little, at least, if not better.
I think it also depends on their thrombus burden and how proximal is the DVT. Like if it's a cable DVT, I'll probably do thrombolysis. If it's just a femoral vein or like common femoral DVT, I probably again I would weigh the patient's functional status.
For phlegmasia, if you have a patient with phlegmasia, then you have to do something, otherwise they're going to lose their leg.
Right.
If they're symptomatic with cerula, albans, or dolans, I'm going to treat them no matter what.
Definitely an exclusion. I think that was an exclusion criteria from the study.
It was that, and I have no idea why they excluded them.
Oh, no matter what they had to bring to the thrombolytic arm, they couldn't randomize them. I think that's why.
Yeah. Brandon, the only thing I would add is obviously also I'd want to what the patient's level of risk tolerance is and what their obviously what the complications and what they
is key. You're right. That's huge. They have to know, be well informed. And in the CaVenT trial, it seems that some of them maybe weren't as well informed because they did drop out after they had been to get catheter-directed thrombolysis. Maybe they weren't. That's something the authors talked about. Maybe they hadn't been educated enough about the procedure, or maybe and they just were afraid of it. But some time we can move on to Ali. Trial. The basically, if you guys have any thoughts throughout, definitely feel free to make Ali the presenter here. If you share my desktop icon there, you should be able to show your stuff.
All right. I'm going to try this very concise and really points trial.
I can.
Okay, perfect. Okay, a little background on this plot published in 2003 in the New England Journal of Medicine. Patients with cancer, they do have increased risk of recurrent thromboembolism despite the use of anticoagulation therapy. And, traditionally, heparin bridging, as we have all experienced during these, and heparin implies constant or predictable monitoring, and as the effect of warfarin is not as predictable as weight heparin. So what this CLOT trial do is to understand and to demonstrate whether a more predictable anti like heparin is superior, or at least the same in terms of its efficacy, or an oral anticoagulants like warfarin, vitamin K antagonists. And the use of anticoagulation in patients is complicated by a lot of things, including reactions, vomiting, thrombocytopenia, access, making it difficult, in addition to malnutrition. So, that exist with the use of oral anticoagulations. So, an alternative set which has predictable pharmacokinetics, in which you don't need to routinely monitor therapeutic drug, that it's rapid onset of action, and importantly, in cancer patients where to stop ambulation, in populations where intermittent, and some where you just stop it and its effect will stop with it, with stoppage of the dose. Some low molecular weight heparin there is advantageous because its effect ceases a shorter period of time compared to oral anticoagulation, and in a much more predictable fashion. To demonstrate whether or not this oral anticoagulation. This was a multi-center randomized trial at McMahon compared to low molecular weight heparin with an oral anticoagulant in the recurrent thrombosis in patients with cancer. So these patients prior event, and the ICE trial was, does low molecular weight prevent an episode in cancer patients who had a prior episode? So these patients, the population was acute symptomatic proximal DVT, 4 people, and 676, 38 patients to each group. One molecular weight heparin, dalteparin, this was the bridging group where they did them for 5-7 days with international units per kilogram body weight subcutaneously every day for days, and for that, they would, within 24 hours of randomization, they also received the full dose of Coumarin with a target INR of 2.5. As that to the being done for 6 months, and the way patients received their anticoagulation, they received a therapeutic dose initially of 2 international units per kilogram for 1 month, followed 150 international units per kilogram for months. So for a total of 6 months each of the therapy. And just a couple of exclusion questions. Or less had a score, performance score. Basically, this is, if you have ECOG performance status of 3 and 4, that basically would be not standard for it. And if they had received therapeutic doses of heparin for more than 44, lit count of less than 5,000, at additions to heparin therapy, at a crack at least 3 times the upper limit of the normal range, return to the clinical center for follow-up alongside. So, I mean, there was 2,736 patients recurrent ETE, and 5,336 patients in the anticoagulation had the recurrent ETE. These patients had about 1/3 of the patients had pulmonary embolism. In terms of which was the primary recurrent ETE area outcome being 15% in delta apparently in full calculation, and the mortality being 9% in the delta apparent group versus 1% in the anticoagulant group, which is to the risk comparisons with in favor of death apparent by 52%. P-value 2.7. So essentially, low heparin being superior to warfarin in preventing the recurrent thromboembolism in the setting of malignancy, but also of there being significant difference in risk of major bleeding with as warfarin, which is another key finding, or fit for that matter. Then to feedback, or what you guys think about this very advantage of low molecular heparin from the get-go.
Who's currently on Coumarin with malignancy and consult for whatever reason, what would you say? Consult for a port or PICC line or something of that nature. What would you do?
Basically before this study, I actually hadn't read the study before, and throughout my intern year, we standardly gave people Coumarin. Results I would say the dalteparin. I mean, it seems like pain to monitor, and I think that these results obviously show that dalteparin is probably transition. Put them on a heparin drip, take them in, put them on a heparin drip, and then do my procedure. And I recommend they transition the patient to dalteparin.
to, like, say patients are currently on Coumarin and you're going to do a procedure, how do you approach those patients?
On the procedure, basically, the SIR has the anticoagulation guidelines, and usually, based on the bleeding risk of the procedure, I think moderate procedure, and basically based on that, I'm going to do in terms of check what parameter am I going to check and what am I going to hold. That much. I usually refer to document.
I mean, yeah, there's always a question is, do you need to bridge them at all? One, can you stop the Coumarin? Usually Coumarin is effect lasts 5 days, so it takes 5 days to be active and therapeutic, or it takes 5 days to kind of wear off. So they should be, if you bridge them, they should be bridged with something. So usually Lovenox or something of that nature. And the question, do you need patients with heparin while you're starting Lovenox? It takes effect pretty quickly within a few hours of injection. So that's the good about the Lovenox or Xarelto. They act pretty quickly as in which, like we said, 5 days, working days.
So one is if you were to Xarelto or something like that, Xarelto. If you switch over to Xarelto, when do you have to stop the Xarelto? Actually, I don't know that.
That's a challenge. It's so new. I always have to look it up because I forget the half-life, right? So what half-life is, if you take one half-life, 50% out, two half-lives, 75% out, it's over 95% of the drug is eliminated. So roughly, 4 half-lives out, whatever the drug is, that usually gives you an idea of when you can stop that medication.
Right. Yeah, definitely. Usually bridge patients on Lovenox or a heparin drip if they're on Coumarin before doing procedures. In the hospital, give them Lovenox, or we'll bridge if they're in the hospital.
Yeah, some people will bridge them if they have venous thromboembolic disease. Some won't. Some people will bridge for AFib, depending on CHADS-2 or CHADS-2 VAS score. Use a score of 2 or greater to say, yeah, you need a bridge, versus less than 2, you need to be on oral anticoagulant therapy. So thinking about these things in the procedural time, what to do. Good talk on novel oral anticoagulants on the SIR-RFS YouTube site from a year ago from a vascular medicine specialist. Or good, so something to view as well.
How often do you trust? How popular is this approach? Even though it was in 2003, I was reading in some, in some places that it's not used as often as I would imagine it would be used. Considering the results of the study. How come across patients who you felt could have been on other way to heparin therapy instead of oral anti.
Yeah, based on this, I certainly advocated, and I certainly have seen it in real practice where patients are in Coumarin. That preference would be, hey, Lovenox would be good for you, from a reduction in venous thromboembolic events and reduction of bleeding risk, and actually even improvement in survivability based on some early stage cancer. So I push for it certainly in these patients based on this randomized trial data. It may be universally accepted, but it's something I advocate for my patients.
Some level of it requires the patient and or their family members to administer this injection, probably just in swallowing a pill. So I would imagine would be an issue. With the study, they phone calls to the patient every 2 weeks and follow up in clinic at 1 week and then 3 months and 6 months. So, I mean, that does help, but in real circumstances, provide that kind of follow-up. I just wonder whether that would do outcomes. Patients may not be able to correctly administer these concerns.
In general, it's like insulin shots somewhat. So I don't think it's from my experience with dealing with patients. I mean, the patient don't like injecting themselves, but it doesn't seem to be too demanding. One is we were talking about. I'm wondering if these oral direct thrombin inhibitors like Xarelto, Rivaroxaban, et cetera, things of that nature, will they replace even Botox? Because it's like, patients that don't need dosing as well, and tell if that will be also maybe the way to go in the future. The challenge with that is it's hard to necessarily reverse those agents, and there's a familiarity with those agents in surgery and whatnot. But those will be the future. So I think we have a go when it comes to venous thromboembolic disease, not only from a interventional standpoint, from a medical management standpoint. How long do we anticoagulate these patients? Extend a DT? What's truly their natural history? And I think it was good to add a quality of life, because is their quality of life really being affected? Is venous dermatitis really going to affect someone's quality of life or not? Is venous claudication that severe that it's really going to bother them or not, or can they get along with it? So their functional existence is really important. It's just not necessarily life-threatening issues, even venous ulcers, and so we need to risk stratify that as well as we move forward in this bed. But I think it's all exciting. The pharmacology, both of the interventional therapies that are available for these patients. And I reviewed the SOX trial at some point where they looked at compression stockings and I think we submitted that up there, but it may not have really made an impact on first-time DVT patients. And when we're counseling patients on that, maybe that's important. It can control symptoms, but maybe it doesn't affect their history. All of this is important for our patients.
Bring up, because there's a lot of good discussions on the chat forum, and this is being recorded, so I wanted people to be able to hear it who are listening. Basically, the discussion about checking fibrin levels with TPA, and it's kind of a mixed response. I think some people like to check them, and some people, if anyone wants to give their opinion on that, I think a lot of times it. But Gusto trial.
Original data was on coronary, and so a lot of what we extrapolate for the periphery is based on coronary data. But again, nothing that we can put our hat on. So it's hard to know. Go to an experiential, not based.
Mm-hmm. Does anyone have any other points?
I just thought it interesting to, the kind of in the Delta variant group versus the oral anticoagulant group. I have them up on the screen. Like in the Delta variant group, we have a patient who had patient who had intracranial bleeding, one retroperitoneal bleeding, and pericardial bleeding. Anticoagulant group events, but they had critical site bleeding, intracranial bleeding, and then retroperitoneal bleeding. It's interesting, not that it necessarily lends itself to a conclusion, but consider the significant difference between the risk of major bleeding and the risk lower delta current. I just thought of the type of bleeding seemed to be delta current than the fragment. You know, the patient status likely interesting. I'm not sure anybody thought.
That's a good point to look at that. I mean, also when I was looking at the CaVenT trial, you know, those patients who had catheter-directed thrombolysis, episodes of bleeding, you know, they weren't affected in the long term. Like, there's no permanent done. And abdominal wall hematoma, compartment syndrome requiring surgery, those are huge. You know, those are huge deals. So definitely, the author had said it wasn't a significant rate, or they had mentioned that the bleeding wasn't significant. I think that's pretty significant. So I think that's important that you made. The patients, you're right. They probably patient selection with the patients able to themselves. So even though they randomized them based on their status. Point. This is great. I learned a lot going through this and talking to you guys, and hopefully we'll have these monthly actually. Gonna have them every month. There's a lot of good articles out there, and we'll just try to keep up and try to discuss some great articles each time. If anyone has any suggestions for, like I said, I'd like to talk about, I'd be really welcome. You know, anything in the vascular or venous disease. I think peripheral artery disease stuff would be cool since we haven't really looked at that yet. Maybe like silver PTX or something, or below the knee trials and inferior vascular. So anything people would like.
Hey, Brandon, it's been Hodge. I think this is a great conversation. Sorry I joined in a little bit late, but I think, yeah, this was because the ATTRACT trials in the news and undergoing, you know, still enrolling. I think there will be several talks on PAD. There's lots of articles in the past 9 months about different stents and how they respond in PAD, and as well as versus versus surgical trials that are going on, including the BEST trial. So I think it's start talking about those things before they actually start happening. The BEST trial will be really interesting.
Manoj is a new attending at the University of Michigan, and he's heavily involved in disease evaluation and management, so he'll be a great addition for our service line here.
Yeah. I mean, right now, that trial is looking at infraposteal arterial revascularization compared to endovascular technique, and currently in open enrollment for people who have experienced years of infraposteal endovascular revascularization. So it's designed by surgeons. So that's one that's basically not a problem, but it's designed by surgeons. So they are kind of skewing the enrollments. It seems that's from what I understand. But anyway, if you're in getting your site, looking from Mount Sinai, New York, is looking for people to join. You have to have a certain number of infraposteal cases. I think it's 20 cases in 2 months or something similar to that, but in 2 years. Actually, you know what? I don't know. But anyway, if you're interested, let me know or let one of us know, or that will see. But anyway, we're actually going to come up with not a PowerPoint, but a spreadsheet of topics where we'll like list articles on a spreadsheet, and people can choose an article, put their name by it if they want to sign up for a journal club to discuss, or if they want to go over a journal topic. It's up. Anyone wants to add items to that spreadsheet, we definitely welcome that too. Thanks everyone. I really appreciate calling. I hope you guys have a great night.
a great night.